Now, this is a very interesting CT scan of the brain. The most important thing of the CT scan of the brain is the CT scan of the brain is going to get repeated itself so many times because this CT scan shows the bleeding in the brain, and this is very, 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 very common. It is extremely common to occur. Now, when we zoom in, we can see that in this is definitely left side and this is right side. So we can see a very hyperdense white lesion in the left-sided brain parenchyma. If you want to localize what exactly is this area, I told in earlier CT scan imaging also that whenever we see these are the ventricles, which are CSF filled cavities. These are the anterior horn, this is the posterior horn, and just beside this ventricles, what we can see is caudate lobe. So this is the location of caudate lobe. This is caudate lobe. This small almond-shaped structure is caudate. You can very easily, very well localize this here that this is caudate lobe. And the caudate lobe is basically part of basal ganglia. It is a part of basal ganglia, which is mainly involved for the movements, muscle movements. So this is mainly involved in coordination, in movements. These are the areas where our uh, limb extremities or extremities movement programs are stored here. And basal ganglia doesn't only end here. This is the part of basal ganglia, and we have one more part of the basal ganglia which is called globus pallidus and putamen, which is located around this area. So this is caudate, and here is the location of the caudate and putamen and the globus pallidus. So the basal ganglia completely comprises of three things. That is, one is caudate, the second is this putamen, and the third is globus pallidus. And these three things actually are involved in movement. So very commonly, whenever there is involvement of these things, these structures, very commonly there will be loss of doing muscle activity, what we call it as paralysis, which is very, very commonly seen. So the third thing which we need to remember is this, that exactly opposite to this, we have a structure which is more large in size compared to this caudate, and this is thalamus. So this is thalamus, which is the relay center for all the sensations except olfactory nerve. So all the sensation from upper limb, lower limb, or in from the cortex, they go through this thalamus. So we can simply remember this structure or this drawing, that this is the typical caudate, this is the putamen and globus pallidus, this is thalamus, and in between these two, what we have is internal capsule. This is internal capsule because here we have external capsule. So this is external capsule and this is internal capsule. So when we see it here, what we can see that the caudate is paired, the thalamus looks kind of spared, though there is definitely pressure over this left-sided thalamus, but the thalamus bleed is not there. And the internal capsule is spared, or internal capsule is spared, though it is compressed by the bleed. So this is basically a typical putamenal or basal ganglia bleed. We must know for in hypertension, the PTPC mnemonic, that is, the putamen is the most common site for hypertensive bleed, which is followed by thalamus, which is followed by pons, which is followed by cerebellum. So this is typical hypertensive bleed or the intracranial hemorrhage in putamen because of uncontrolled hypertension. There is one more thing I need to show in this imaging is there is not only bleed, it is causing pressure effects nearby. Though there is no significant midline shift, the midline shift we can see it is in the center. If you see, this is the midline, and midline appears almost in the center. But compare the ventricles. This ventricle is kind of very wide, whereas this ventricle is pretty slim or narrow, or it is like slit-like. So this is because of the compression and the edema around the bleed. That is the reason why it is putting pressure not only on the lateral ventricle, it is putting pressure on the thalamus. And if the bleed eventually increase, there can be midline shift. So this is not an indication of surgery. Here, the systolic blood pressure has to be controlled. It has to be between 140 to 160 millimeters of mercury. It can be given by, it can be done by using infusion of injection labetalol, or it can be done by using injection NTG. But most of the time, injection labetalol is uh, preferred or used. The other things is if the patient has significant midline shift, is there is worsening of sensorium, or if there is uncal herniation, or if there is brainstem herniation, this can be the indications for surgery. Or if there is bleed which is very very large, which is compressing a significant amount of brain parenchyma, or if there is significant intraventricular bleed, then these are the indications of surgeries. But otherwise, a stable intracerebral hemorrhage is not an indication for craniotomy or surgery, and it can be managed medically as well with strict blood pressure control and with use of antiepileptic drugs to prevent convergence. Thank you. That's all for today.